Welcome, everybody. It's Dr. Linda, along with the VBF Sturge-Weber syndrome expert, Dr. Ann Comi of the Hunter Nelson Kennedy Krieger, the Hunter Nelson Sturge-Weber syndrome Center at the Kennedy Krieger Institute in Baltimore, Maryland.
There we go.
Happy Black Friday, everybody, and welcome, Dr. Comi.
Thank you.
So today our topic, we already see Vanessa is on and Aaron. Hello, ladies. And our topic today is Sturge-Weber syndrome and also its association with port wine stains. VBF gets a lot of questions about what the risks are, when to get tested, when are you out of the woods, if you are out of the woods, what do the seizures look like, what drug therapies that you can use. So hello, hi Vanessa. You can start sending your questions in right away. Also, this June, Dr. Comi will be with the VBF I team in Greece. So any of you that are tuning in from Europe, you can come to our free clinic June 7th and 8th. And we will be posting about that in the next 2 weeks. And also our conference is in California, Columbus weekend of 2019. And we'll be posting about that as well. Hello, Kiana from Trinidad. Hi, Kiana. She's starting to be a chef, so she's doing a lot of sessions on cooking. I like watching her cooking classes. Anyways, thank you, Dr. Comi. And while we're waiting for the first question, is there anything new that you can tell us about your work or research?
Well, one aspect that is new is that a medication that we studied and recently published on our drug trial, Epidiolex, which is pharmaceutical grade cannabidiol, has recently been FDA approved for 2 other epilepsies in children, Dravet's and Lennox-Gastaut. And that's really great news because it's now, just this month, is clinically available. Doctors can prescribe it. And we studied it in a small number of children with Sturge-Weber syndrome who had very hard to control seizures, medically refractory to multiple seizure medications. 3 out of those 5 patients responded to the Epidiolex. 1 became seizure-free and 2 others had greater than 50% decrease in their seizures. And it was pretty safe. And actually those 3 patients had bilateral brain involvement. And so it looks like that's going to be possibly a new good option for patients with Sturge-Weber syndrome. We're hoping to be able to study it further. There may be other aspects of Sturge-Weber syndrome that also will respond to this new medication.
Well, thanks, Aaron. Aaron said that everything you just said was every question she had. So way to go. We're right there. We're right on the forefront. I am very excited to hear about this. So I hope that when you come to our conference in Greece and in California, you'll be talking more about this and, maybe trying to get some more of our doctors in the country to start using it and maintaining some data so we can get some national, joint efforts to get this out there. People don't realize it, but even with regular medicine, it can take 8 to 10 years to get something in the general population. So think about how hard it is in our world. Oh, you lost sound. Sorry, Jelena. I hope you can hear us now. Hi, Scott. Can you hear us? Can everybody hear us? Because Jelena said she lost sound. I just want to make sure that's not something wrong. Oops, let me get rid of that. Okay. Here we go. Looks like we're going to have a question pop up. Let's see if there we go. Everyone else can hear? Yes. Okay, she'll try again. Yep, Kiana can hear. So let's start seeing some of your questions. We're ending at 2 o'clock, so we have 56 minutes left. Okay, go ahead, Jelena. Go back out, come in, make sure your microphone's on. And Kiana says she can hear. Oh, we might have a question. Let me see. Okay, you can hear. Okay, you can hear. Okay. Must be me. Sorry, Jelena. I don't know, try on your mobile device or try on your laptop. Sometimes you have to initiate the microphone. So we're waiting to receive your questions. Hi, Josie from Europe. Dr. Comi was just talking about the FDA approval of the new Epidiolex for patients with Sturge-Weber syndrome. Right, it's for seizures.
That's correct.
But it'll be now available for people with Sturge-Weber syndrome because they fall in the category where the drug has been approved if they have the seizure.
It's approved for Dravet and Lennox-Gastaut, but we expect that with time and further study, that gradually it'll become available for other causes of epilepsy, including Sturge-Weber syndrome, and we're working on getting additional studies together to be able to further study it. Looks like it's going to be helpful.
Are you still taking patients in on,
We're writing grants and putting together further studies. So yes, we expect that there will be new studies available in the near future.
So Aaron wants to know, what would a seizure look like?
So seizures in babies with Sturge-Weber syndrome usually are focal. So a lot of new parents make the mistake of thinking that it's going to be generalized shaking of the arms and legs like they see on TV. And that's usually not the case. It's usually twitching of the hand or the foot on one side. It can be the eyes deviated over to one side and then bouncing, or the side of the mouth drawing to one side and twitching. And that not just for a couple of seconds, but a minute, 2 minutes, 3 minutes, it could keep going. That's the most common kind of seizure in Sturge-Weber syndrome, both babies and children. Sometimes the head turns to the one side while the side is shaking. A less common seizure could be staring, that you can't get the child to stop, or a rare kind is more like spasms, like this, a sudden jerk. The head and the upper body jerks forward.
So what's the most common, the minor little shakings, you think, or the twitching?
The focal seizures, yes,
focal.
That's the most common kind.
So Lauren has a question for you. Her daughter has bilateral involvement but has never had a seizure. We're doing preventative meds, trileptal and aspirin. She's now almost 3. At what age would you recommend trying to come off the medication?
I would continue the preventative care until at least 5 to 6 years of age. So the data that we don't really know, preventative pre-symptomatic treatment is relatively new. We've been doing that as well, or offering that for parents who want to go that route for the last several years. And the ideal time for coming off of the pre-symptomatic treatment is not exactly known, but one might think that from data that's out in the literature that Sturge-Weber syndrome tends to stabilize in terms of the blood flow, the metabolism around 4 to 5 years of age. So if we can get the patient beyond that to maybe 5 or 6 or 7 years of age, and wean them off the medication then, that they would continue to do well, hopefully, at least until puberty, when there can again be issues.
So Vanessa wants a document about the red flags. Well, she can go back and view this video, but maybe that's something we could work on.
Yeah.
Is coming up with a little fact sheet about what a seizure may look like. Lauren said her neuro seems like he is already ready to try lowering. Since she has never had a seizure. However, we feel like we don't want to change to a good thing and knowing it could still happen. So
yeah, I would wait until at least 5 years of age.
Aaron wants to know, when do you recommend an MRI?
So if a child has the put one birthmark, the upper part of the face, from the outer canthus of the eye out to temple region, involving the forehead or the upper eyelid, or the mid forehead here, then they're at risk for Sturge-Weber syndrome brain involvement. And I recommend a neurologic exam and history and an EEG. And if those are okay, repeating that when the child is 3, 4, 5 months of age. And if that's still okay, then doing an MRI without contrast and certain sequences after a year of age. We're sometimes now doing, if we see the baby young enough in the first couple of months of life, a wrap and go MRI without sedation, without contrast, because that's completely safe. And if we see, sometimes we will see abnormalities on that. We add that to the exam, the history, and the EEG. And if we see abnormalities on that, then going ahead and doing the sedated, contrast enhanced MRI.
What about for the check for glaucoma?
So that should be done in the newborn period before the child goes home, first, if at all possible.
I mean, right at the hospital?
Yeah, because there can be glaucoma in the first week of life.
So, but the thing is, like, that would be the neonatologist's call, right? Like, would they know to do that?
Or the pediatricians.
I mean, they don't go to the hospital, though.
Yeah, they don't normally anymore, but yeah, so ideally, but then if not, then
Maybe
as soon as
an
possible,
early
really.
checkup.
Yeah, really is,
Maybe that's something we could work on too, is like we've included in the 4-week well baby checkup, to check for for the birthmark, but maybe to also make sure they're screened, they have their eyes screened if it's in the.
I mean, it is happening in hospitals.
Yeah.
It's just not maybe happening everywhere.
Yeah.
But in hospitals where someone makes the connection between the birthmark and Sturge-Weber syndrome, the consult is called for the neurologist to see and an ophthalmologist to see, and the baby gets a glaucoma check before they get sent home. That just doesn't always happen.
Yeah, I guess kind of like when a baby's born with a cleft palate, you don't get the whole full team, but you do get at least somebody who knows how to get the testing.
It's actually probably more important for the ophthalmologist to see the baby than the neurologist, because the neurologic problems are less likely to present in the newborn period than are the eye issues.
And, this question that comes up often is, when my baby was checked and doesn't have any brain involvement, and they're 1 and then 2 and 3. So then are they out of the woods? Or
if they had proper imaging after a year of age and it's completely normal, then yes, basically yes. I mean, nothing's 100% in this world,
right.
But basically yes.
Hi, Aiden. And then Andrea Rocuria said her almost 5-month-old baby has a port wine on 80% of his face. His right eye is surrounded and presents with glaucoma. His left one's just on the upper lid. So far, no seizure, and his development is normal, as confirmed by the neurologist. We didn't perform any brain scan. They suggested us to wait until he's 1, but we wonder if there's still a possibility of no brain involvement at all.
There is a possibility of yes. So from the birthmark that you described, the risk of brain involvement is probably around 40 or 50%. Maybe with the glaucoma, probably more like 50%. So that means, yes, there's a chance of no brain involvement.
So then are you saying, like, if there's more extensive facial involvement like she just described, and that
higher the chance.
It is higher.
It is higher chance, and you have eye involvement as well.
Yeah.
So
bilateral.
Bilateral, yeah. So there is a high chance, and I would suggest getting the EEG to take a look, because that's also a perfectly safe test. No medication, no sedation, just an hour and a half. And if there's any abnormality on the EEG, then that can help decide whether to move up the MRI. I mean, one would only do that really if you would contemplate doing pre-symptomatic treatment. If not, then you can wait until after a year of age. MRI.
Oops, sorry.
I mean, what?
Sorry. Aaron said, so if there is a port wine stain by the corner of the eye, ear, and temple, they are at risk for Sturge-Weber?
Right. So 90% of patients with Sturge-Weber syndrome brain involvement also have a port wine birthmark on the face in that area here. Okay, the upper part of the face. If it's on the lower part of the face, then there isn't this increased risk really of brain involvement. 10% of patients don't have a birthmark, they just have the brain involvement.
Wow, really? And how do you know that it's Sturge-Weber?
They present with seizures at some point, and someone does an MRI with contrast
and sees the calcification?
Or just the abnormal blood vessels, leptomeningeal enhancement, really. Yeah.
Wow. So Jelena says, you mentioned issues may start or restart around puberty again. Are boys and girls any different? One's in higher risk group than the other?
That has not been directly studied, not that I'm sort of aware of from clinical experience.
Hi, Corinne. Vanessa says, if you're cleared for Sturge-Weber as a toddler child, can it develop later in life?
If you normal development, normal, no history of seizures, and an MRI with or without contrast with sequences, but basically an MRI with or without contrast done after a year of age, then we consider them basically cleared.
So it really is about the testing, because some of the parents will get an MRI done, but say it's not done with contrast.
Right. It has to be done with contrast.
Right. So then they think it's clear and that they're out of the woods.
Right. And that does not clear the eye. The
Right.
eye involvement, the risk of that remains lifelong. Particularly the highest risk is if the birthmark covers the upper and the lower eyelid. If there's upper and lower eyelid involvement, or really involvement anywhere involving the eyelids, then there remains a high chance of glaucoma developing any time during the life, and the patient needs to be seen at least yearly throughout their lives.
And is that's Sturge-Weber type 2, right? Where it's just the glaucoma and the stain, but no brain involvement. Right. Colleen wants to know, her daughter had an MRI at 1 month that was clear. Should we retest now that she's almost
a year?
Yeah, yes.
That's right. An MRI done in a month of age does not establish whether the child has brain involvement or not. That has been shown repeatedly. Many people have reported.
Almost 5.
Oh,
she's almost
yes.
5. Yeah.
Well, so yes, if you want to know for sure, the MRI done in a month of age does not exclude brain involvement, and so 75% of patients with brain involvement will have onset of their seizures within 1 year of life. About 85-90% within the first 2 years of life, but 10% or so will have onset of their seizures after 2 years of age, and it can be at any time: childhood, adolescence, adulthood. The oldest patient I ever saw or have seen with onset of the seizures was in her 60s.
Wow, for the first time.
For the first time.
I know we had one of our Sturge-Weber chapter director from Canada, Tom Gilbert.
Yeah.
He presented in his 30s and ended up with a hemispherectomy.
Right. So these are patients who either, most of them never got imaging at all.
Right.
And
or
then,
inappropriate imaging.
Right. So, but imaging at a month of age does not rule out brain involvement. We have all seen patients who had very early imaging, and they were told they're out of the woods, it's fine, and later on presented with seizures.
Aiden sent a question, but it needs the English translator on it. So resubmit it, Aiden, and click and allow for the English translation so we can see your question. Hello, Christine. So my daughter joined, I guess. And Glenda. Hi, Glenda, our Sturge-Weber syndrome ambassador. Stephen Booth said he has a port wine all over his right eye and all over his scalp. I'm amazed I don't have Sturge-Weber. Blessed.
Yes. So, but all takers.
Yeah.
Many patients who have a birthmark on their face and eye don't have brain involvement. So,
yeah,
not everyone does.
Right. So Colleen says 60. Really? So far, we haven't had any. I don't know what that is reference to. 60, really? I'm not sure.
Maybe 60 years old.
I don't know, maybe. And really, we haven't had any. Because you made that comment that the oldest one you had was somebody that was 60.
That's right.
So, but look, people can develop epilepsy at any time in life too, right?
Right.
So, I mean,
Well, but this person actually had brain involvement on MRI, just had never had an MRI done before.
oh,
But overall, just remember, even for the parents of the young children, when I see them and a child who has a birthmark, say on one side, if it's not real large, their child has maybe a 20% chance of having Sturge-Weber syndrome brain involvement. And so there are many patients who have a birthmark on one side of their face who don't have Sturge-Weber syndrome brain involvement. They just have a increased risk of it until definite imaging after year of age establishes whether they do or they don't.
so, and then once someone has a seizure, will they then be more prone to seizures?
Yes. Yes.
Is there some kind of a exponential factor with this, like, or can it be like remitting, relapsing, and then more progressive?
Really varies. So some patients have seizures that are relatively easily controlled, although that's most frequently the patients require a couple of seizure medications and often low-dose aspirin to control their seizures. And so there's a smaller number that are easier to control than that, and then there's a smaller number of patients that are very difficult to control and may need other seizure medications or even other surgical interventions or ways of treating their seizures.
Should somebody that even has a port Weinstein in the at-risk zone, should they just prophylactically take a low-dose baby aspirin, or?
I have not recommended that because low-dose aspirin, while pretty safe, is not 100% safe. It does thin the blood a little bit, and so if the baby was ever in a fall or in an accident, it would be expected to bleed more than might otherwise. Plus, there is a very low risk of allergic reaction to aspirin. So it's not, while very safe, and we've had many, many patients on it for years, it's not completely without risk. So we don't put patients on it who don't have brain involvement. Same thing with our current approach to pre-symptomatic treatment is a seizure medication such as trileptal and low-dose aspirin. And same thing with the seizure medication. While it's an appropriate thing to do if you're trying to prevent seizures with someone who's at high risk, we wouldn't want to put a child with a normal brain on a seizure medication.
So Colleen said, thank you so much for the information. She's been following you over the years and that you've given her more information than any of her doctors. And she said she loves us. So we love you too. Batul joined us from India. Hello, Batul. And Corinne, Corinne is our VBF family expert. She said she's friends with Ann Cody O'Neill, who's a friend of yours. Okay. So I guess that's a shout out from Corinne to you. Jelena says, can I please widen my question regarding boys and girls? There are no studies. Sturge-Weber syndrome can affect both equally at any point in life. I am thinking when my daughter with Sturge-Weber syndrome is older, pregnancy, etc. Okay, so there are, I guess I meant that there's not been a study to show whether puberty in boys or girls are more likely to result in seizures. That was the question I was trying to answer. It does occur equally in boys and girls. We have data coming out in a paper suggesting that the cognitive issues may be more common and significant in boys with Sturge-Weber syndrome. So we have recently found that difference, and that's actually been we're publishing it now, but that's been a sort of recurrent or consistent difference that we've seen in our data, and now we're sort of publishing it. With regards to pregnancy, we haven't sort of published anything along those regards, but we do have, and I would suggest that any
woman who with Sturge-Weber syndrome is pregnant be followed as a high-risk pregnancy, but it can be done and has been done. And both men and women with Sturge-Weber syndrome can have families and have children, and their children don't have Sturge-Weber syndrome. It's not passed along because it's a somatic mutation.
So Levita asked a question that may or may not be applicable. She said, can a hemangioma come back after surgery? So if she's talking about an infantile hemangioma, the kind that appear at or shortly after birth, if they're partially excised, we know that they can have some rebound growth. Now, if she's talking about some tissue hypertrophy related to a port wine, that too can come
Yes,
back,
it
correct?
can. That's right.
So either way, I guess the answer is yes.
Yes.
There can be some rebound growth after surgery. I'm not sure which in particular she was talking about. Okay, again, screen is cuckoo. Glenda said hello to you. Glenda, April said, Dr. Comi is our daughter Ava's neurologist for Sturge-Weber. She's the best. Such a blessing to have her.
Thank you.
Hi, April. Happy day after Thanksgiving. So we still have time. We have 30 minutes left. And once again, just remember, this is your opportunity if you're a child or if you're an adult with Sturge-Weber to ask your questions, or if you or your child has a port wine stain and you are concerned about the relationship between Sturge-Weber and a port wine stain, this is a good time to answer your questions. Very excited about the research that you talked about. And I don't know, I know you're saying hopefully soon you'll be able to start getting some people to script this. Like, what are you thinking in the next year? Or?
Well, so right now the insurance companies are still sort of working on the best way to get this out to patients who have Dravet's and Lennox-Gastaut, and so then that will be worked out for the insurance companies, and insurance companies will get used to that. But for our patients with Sturge-Weber syndrome, we're going to have to see how easily it goes in terms of getting insurance companies to pay for it. But that's part of the reason why we're trying to also get another study, a larger study going, so that we can better justify it to the insurance companies, demonstrate the benefit, and also provide the opportunity for those who are interested to obtain it in the meantime. So we'll have to see.
Yeah,
how
sounds to me like 2 years.
Yeah, we'll see. It could be
sooner.
Yeah.
Okay, so Katie says her 12-day-old daughter, congratulations, has a port wine stain on her forehead and head. What is a percentage rate she will have Sturge-Weber? We're undergoing tests this month, so apparently somebody else must suspect it. So.
Right, forehead and head. So on one side or both sides?
Yeah, Katie.
I need to know the size.
How far it goes down on the forehead.
Right.
Yeah. So,
I mean, sometimes people send me pictures.
We can't see them here, but we post Dr. Comi's email link through VBF on here through the scrolling of all the comments, so you can look. But Katie, just send us like exactly where is it on both parts of the forehead, left to right? Does it come down the middle and go over on one side?
But I can give you some general ideas. Okay. So if it's on one side and it's smaller, involving mostly just the forehead or an upper eye, then we're talking about a 20% risk. If it involves most of one side of the face, so it's the forehead over the eye plus down onto the cheek, it's more like 25%. If it's both sides and involving most of both sides, then it's 35 to 50% chance. And if you've got eye involvement too, meaning you have glaucoma on top of that, then it's 50% or more.
That's good to know. That's stuff we got to do a little document with a little schematic, unless you have one.
Okay.
So Stephen said, do you honestly think there will be any complete cure to get rid of a port wine stain rather than just a laser to fade it?
So the end game, most likely, and that it's not going to happen right now, but perhaps 10 years from now or so, perhaps 20 years from now, is going to be gene therapy. Okay, so I was at the Child Neurology Society meeting just in October, and gene therapy is going real time now for other very severe conditions, lethal, fatal conditions, and it's working. And so.
And you found the Sturge-Weber / Port Wine
Right.
stain gene, so we have already identified the gene.
Yes, we have the gene.
And that's exciting. That was really exciting.
Yeah. So that's I think where it's going to happen. It's going to start out as treatment for very serious and fatal conditions, and then as that gets worked out, it'll gradually work back to other things like Sturge-Weber syndrome and port wine birthmarks.
Yep. So Aaron, yes, you can send your photos and questions to Dr. Comi through the VBF at Comi /birthmark.org, or you can go to our website at birthmark.org and you'll see her picture and name and our scrolling images of Ask the Expert, or April, our social media person, can post on here, or Corinne, Dr. Comi's email. So we'll put it right in the string for you. Andrea said, if the scan reveals involvement, is that a sure sign that the patient will suffer from seizure and cognitive issues?
Not absolutely 100%. Epilepsy or seizures occurs in a very high percentage, but it depends on the extent of brain involvement. So if it's just a very small area on one side of the brain, then that patient has probably a 75% chance of epilepsy or seizures developing at some point in time, but a much lower chance of significant cognitive issues. If it involves one side of the brain, and much of that one side of the brain, they have a much higher chance of some learning disabilities or cognitive issues, attention deficit. If it involves much of both sides of the brain, then they have a very high chance, so 95% chance or more of epilepsy, seizures beginning at some point in time, and of significant cognitive issues. So two main predictive factors have been shown in many studies repeatedly over the years as being predictive factors for neurologic severity, and those are extent of brain involvement and age of seizure onset. Another factor that we have found more recently to also have some prediction is the extent of the port wine birthmark, but that's less of a factor. The two main ones are extent of brain involvement and age of seizure onset. So the earlier the age of seizure onset, the worse the seizures, the harder to control the seizures, and the worse the neurologic. And that's part of the rationale for the pre-symptomatic treatment to prevent or at least delay significantly the age of seizure onset.
A lot of questions coming in now. Gail says, hi, I'm not sure if you remember Jack Greenwood.
Oh,
That's
yeah,
his
sure.
son. He's
Of course,
now
yeah.
14. You saw him as an infant.
Yeah.
He has V1, V2. He's seizure-free, no cognitive defects. I'm wondering if the children you test for Sturge-Weber with V1, V2, what percent test positive for, like, I think she means Sturge-Weber. I mean, V1, V2 port wine. What percent will test positive for Sturge-Weber?
So, and if I recall correctly, his was V1, V2 on both sides of the face or one side of the face. That was years ago. I think.
She didn't say, but it'll pop back up.
Because it depends on whether it's unilateral or bilateral. But even if it's, like I said, even if it's bilateral V1, V2, it's still 50%, perhaps, not all.
Batul has a question about AVMs. I'm not sure if you can or want to answer it, but we do have a new AVM expert. Yeah, she can answer it. Or she didn't ask the question. But if you want, because I know she has it in her extremities, now that we have a new AVM expert in Europe, Batul, I can put you in touch with Dr. Coletti. He's on the VBF website at birthmark.org. You'll see his name is Giacomo Coletti, Dr. Giacomo Coletti out of Italy, and you can email him directly through the VBF website. Katie said it was both sides.
Yes,
for
yes.
him.
So
you
50% or so.
So the woman who asked about the hemangioma, so her son's been taking propranolols, now off, scheduled to have surgery in January. He'll be 2. Is it recommended to do the surgery? It is a strawberry mark on his forehead. I mean, again, she can ask some of our surgical experts because it's all what's the size and
Right. I mean, that's not my area of expertise.
So then Katie said down to her nose on the forehead in the middle. She also has port wine on her whole body, arms and legs. So that was Katie who asked some questions before about the wrist, both sides.
Okay.
Oh, so Jack has, oh no, that was Gail. Gail's got Katie, both sides. So she must have been, let me go back to Katie's to find out. Oh, 12-day-old. She's got okay, so it's on her forehead and her head, both sides.
Okay. All right.
So yeah.
So there again,
and it's on parts of her body.
Okay. So about 50% chance if it's most of both sides of the face, and certainly both forehead, both over both eyes. So about a 50% chance. And I would definitely look to get the EEG done. And in a 12-day-old, now we'll often try to get a wrap and go MRI, meaning in newborns or very young infants, they don't need to be sedated. They can just be fed and then wrapped up in their blanket, and they'll go to sleep and be put in the MRI and do a non-contrast MRI, it can be done and look to see if there's an enlarged choroid, if there are abnormal vessels on SWI, any evidence of calcification or atrophy, anything that suggests that there's abnormality there. And if there is, then go ahead with the sedated, contrast-enhanced MRI to make the diagnosis.
So Leslie is watching from the UK. Hi, Leslie. Deborah has a question. She said, is weakness on one side of the body and less use of one hand the same thing as cognitive impairment?
No.
Or could that be related?
It can be related. So we actually published a study several years ago with the medical rehab specialist that I've worked with several years ago, for several years, Dr. Stacy Suskauer, showing that young children who have, it's called hemiparesis, meaning one side that's weaker than the other at a young age, those children are at increased risk for cognitive impairments, meaning that the intellectual or learning disabilities or intellectual impairments. And so those children who have weakness on one side should be seen by a developmental pediatrician or a neurologist, and receive what we call neuropsych testing to look for cognitive issues, look for learning disabilities. So yes, the hemiparesis can be a sort of early indicator that they need to be evaluated.
So Gail, that's the mother of the boy that
Yes.
saw it. She said he does have it on both sides and most of his body.
Yes, and as I recall, we looked very closely for any sign of brain involvement, and he did not have. And so if appropriate imaging is done after a year of age and there's no sign of brain involvement, then there is no sign of brain involvement.
So Louise wants to know if there's any news with port wine stain treatment and prevention. I don't know what prevention.
Yeah, no, I don't think so. We know that a somatic mutation in GNEQ is the cause of port wine birthmark, certainly the face, and with regards to Sturge-Weber syndrome. We don't know what we don't, and we know that somatic mutation is very common. 1 in 300 births have a port wine birthmark somewhere. But what we don't know is there some trigger for that. Somatic mutations are very common throughout all of our lives. They're happening all the time. Most of them are silent, but this is a very common one. What we don't know is if there's some exposure that is triggering these, not that we're aware of. Since we don't know what, if anything, may be triggering, we don't really know how to prevent it. With regards to treatment, the newest thing, and Linda has other experts that can speak better to this than I can, are the inventions and discoveries with regards to lasers themselves. And then some dermatologists, vascular dermatologists, are using topical sirolimus in conjunction with laser. And what we're finding, and this is work Dr. Bernard Cohen in our center, he's the vascular dermatologist. What he's finding is that in patients who are plateauing, they're not responding anymore to laser. That then adding the sirolimus with those patients is helping. And I think that's probably because, for whatever reason, those patients are having an angiogenic response to the laser, and the sirolimus prevents that.
I know there's a lot of controversy over that.
I understand.
Yeah, so.
I understand.
Yeah.
But I think probably if you give it to everybody,
Yeah.
some patients don't need it. They're not having an angiogenic response. The laser, eliminates the blood vessels, and it's all they need, and they have a great response to it. But some patients don't have a great response to it, and it seems that in some of those patients, the sirolimus helps, but that's still being studied.
So, Batul, to answer your questions, VBF just posted someone from our team, Dr. Coletti's email. If you look above, you'll be able to see that, because she has a question related to KTS. Brianna has a great question. So her son Phoenix is 10 months old, and he's had all 3 vascular malformations: venous, capillary, and lymphatic. And he has KTS in his hand into his arm and his side on his chest. He just started his treatments for sclerotherapy. He has block released bumps on his hands. Do you think they can explain what this is? Block listed bumps on his hands. I'm not sure what that word is. He might be trying to translate. But yeah, I know you don't do, if that's a question related to sclerotherapy or embolization, then he can contact one of our, that's a good question for Dr. Coletti as well. So Brianna, I'm not sure where you're from, but we just posted above our European expert, Dr. Coletti. He's our diagnostic expert for Europe, and he's very good, very comprehensive. So you could ask him that question. Okay, so Dr. Comi's email's been posted, and Dr. Coletti's. So that means we're caught up. Okay, let me just, we have 15 more minutes to take some of your questions.
There's a couple more things just while we're waiting for next question.
Mm-hmm.
We try to let families know that that it's important to, if your child has a seizure or an episode of weakness, oftentimes when you go to the emergency room, the doctors will want to get a head CT, like every single time, because they're worried the child has had a bleed or a stroke, but really a bleed. And head CTs are good for looking for bleeds, but
what is it? A head?
Head CT.
Oh, a head, a CT,
yeah, CT
a
scan, a
CAT
CAT scan of the head.
Okay.
But patients with Sturge-Weber syndrome, even though there's abnormal blood vessels there, it's very rare for them to bleed. And even when there is a bleed, usually the bleed is very small and subdural, and it's not something that has to be aggressively treated. So, and there's a reason. So for head CTs, CAT scans involve radiation. And so to get one done, not a big deal, but to get them done repeatedly over years is probably not a good thing. And so if they if the ER doctors or physicians really want to get imaging done, they should request a rapid MRI. Many places can do that now. And so they should just be reassured that that's very unlikely. The somatic mutation is also thought to be a driver mutation and may increase the risk of further mutations. And that's another reason to not want to be doing repeated CAT scans.
Very interesting on that. So Susan is new. She said, hello. I joined late, so I apologize if you've already discussed it. And can you talk about reading problems caused by Sturge-Weber versus reading issues being caused from seizure medications that are being taken to control the seizures? We are considering changing medication to help with the learning issues, but we have Emily's seizures well controlled. So if it is unlikely to help, don't want to change.
The only seizure medication that is really known to have language issues per se is Topamax. And so that patients can have word finding difficulties with that and language issues. So if we see a patient who's having those kinds of issues, then we often will try to change them to another seizure medication. Reading disabilities does seem to be common in patients with Sturge-Weber syndrome. We're actually currently just getting started analyzing the data that we have on that. So I don't have numbers or the data on that. Hopefully next year,
that's really
I
interesting.
will be able to speak knowledgeably about the details on that. But yeah.
Is that a cognition then?
Yes,
problem?
yes,
Yeah,
that's a cognition
cognition.
issue. And something that we've just started to sort of become more aware of that part of the profile.
Yeah, how specific that is. I mean, I think
Right.
that's really an interesting clue. I really think it is. So Jill has a question. Her 21-month-old daughter has a port wine starting at the corner of her eye and glaucoma. And recently she is blinking a lot. Is that anything to be concerned about?
So yes, so tearing of the eye, increased redness of the eye, pain in the eye, irritation in the eye. Those are all reasons for you to contact your eye doctor and ask to be seen. I just saw a patient in the past week or two where they had multiple normal visits with the ophthalmologist. Everything seemed to be fine, but now their child, very young child, had been waking up, and just in the mornings there was increased redness, red blood vessels in the white part of the eye, and I told them that was cause for concern and they needed to be seen by their ophthalmologist.
Okay, I mean, that's a little scary, but better to know that it's related.
Well, right, and you know the thing is with the eye involvement, the whole issue with sort of screening is that you want to catch it early. By the time that there's vision loss in the patient, it can be too late to reverse the changes. So you want to catch the increased pressure before there's vision loss.
That's an interesting question too, is with the vision impairment, with the glaucoma and the seizures, are either of those reversible once the damage has been done?
So with certainly the glaucoma, meaning, well, increased pressure in the eye is reversible. If you have actual damage to the optic nerve from the increased pressure, then that in itself is not reversible. And so that's what we're looking to prevent.
Right, that's why you want them checked as soon after birth as possible.
Right, and then that's why there needs to be frequent checks for the first few years of life before the child can tell you if there's pain in the eye or they're having trouble seeing, or before they can have good vision acuity checks. With regards to the seizures can certainly be treated with medication and epilepsy in a certain number of patients can be fully controlled, and some patients even come off their seizure medication later in childhood. And neurologic deficits, meaning visual field cut, lot of visual deficit because of eye involvement or weakness, or even cognitive impairments, those can be reversible. Some patients, it's common for there to be more of those neurologic problems when they're having a lot of seizures, and if the seizures become fully controlled for a year or more, for those deficits to improve.
So it just sounds like what you just said is really, really critical.
Yes.
For anyone with the Port Weinstein in the suspected regions, even if it's just slightly there, to get the glaucoma check and the imaging done at least once for the imaging, just because you want to try to prevent any progress in the disease.
Well, it's really important for the eyes to
Especially
be
the eye.
screened regularly, and to be, if there is increased pressure, for that to be diagnosed early. I think it's really important for newborns who have the birthmark, for the issue of potential for brain involvement to be raised, so that they can be followed closely in the first year of life, and the parents know what to do if seizures do start, because I make sure that they have Diastat on hand. That's a seizure medication. They know what to look for, what a seizure looks like. They have a seizure plan in place. They know where to go. They know how to get care quickly. And because we want to stop the seizures as quickly as possible. Prolonged seizures in young babies are associated with a stroke. So we want to get the seizure stopped as quickly as possible, to try to get the seizures under control and keep them under control as well as possible. And we want to make sure that if they are diagnosed, that pre-symptomatic treatment is considered when appropriate.
Well, I'm glad that you're saying all this, because I get so many messages on the 60+ Facebook groups I monitor, and I think it's safe to say now that our Sturge-Weber expert says the sooner the better for the eye exam, and that they can actually be sparing their child's eyesight, by doing
absolutely.
that soon. And then that the MRI should be done by age 3 or?
So it can be done anytime after a year of age, and different. I've seen, I would say, like 2/3 or 3/4 of the parents decide to do it sometime between 1 and 2 years of age. They sort of want to close that book. Okay? They want to know, so they stop carrying the Diastat with them. They can stop worrying every time the child has a fever or cold that they're going to have seizures. There's a smaller group that they decide, well, maybe I'll get the MRI when I don't need to sedate them anymore. So there are a group of parents who do that, but it's a much smaller number.
So between 1 and 3, like maybe. So there was a good question that came in through the foundation, through the back end, and it said, I met Dr. Comi at the VBF conference, and she suggested I get an MRI of my face to determine if I had Sturge-Weber or a hemangioma. I'm wondering what type of MRI I should ask my doctor to order and what the radiologist should be looking for. I have a doctor who is willing to order an MRI. I have not received any response from Dr. Comi by the email on her card, which is surprising. Just email me too to verify that number. Email me, or as we have in here, we've posted Dr. Comi's email. So surprising, right?
So I think that I got that email in the last couple of days, and so I will respond to that. Thank you for sending this. Yeah.
Okay, so we have like 5 minutes left, and April says, are there typically any warning signs before a child has a seizure? One that is well controlled now with seizure medication, I mean.
What's that?
Are there typically any warning signs before a child has a seizure? One that is well controlled now with seizure medication?
Not necessarily, not really. So a child can be well controlled and then get sick or just start having seizures again. One thing I would say that's really important is that infants and young children grow quickly. They gain weight quickly over the first few years of their lives. And what should be happening is that every 3 to 4 months, you and one of the child's doctors check the weight. And if they gain 5-6 pounds, then, or, well, I guess more like, yeah, 5-6 pounds or so, then the milligram per kilogram dose be recalculated and go up on the dose a little bit. And that way, they won't outgrow the dose of their seizure medicine and or aspirin. Otherwise, if they just are put on the dose and they kept on that same dose for 9 months, 12 months, at some point they'll start seizing again. And that seizure episode could be a big one. They could have another stroke or stroke-like episode and setback. So it's important to just go up on the dose by a little bit every 3-4 months over the first few years of life.
Is that a weight issue, like milligrams per kilogram?
That's right. It's milligrams per kilogram. So what should be happening is that when you are at a dose that is controlling the seizures, ask the doctor when they put you on that dose, how many milligrams per kilogram per day was that dose? And then if 3 or 4 months have gone by, ask how many, what's the weight, and then calculate a new milligram per kilogram per day dose. And if that has gone down a fair bit, then they need to go up on the dose. And that's not really increasing it, it's keeping it the same.
Right. I was going to say, because especially in infants, kids under 3 have massive growth spurts.
I mean, they double their weight.
Double, because you go from 10 pounds to 20 by age 1, and then you've literally tapered yourself to a 50% drug dose.
That's right.
So you're not really getting,
exactly
that
right.
makes sense. Yeah. So that's really good advice. Okay, so I guess that's the last question I see right now. It says there's a new comment, but I think we just answered it. So we're winding down with 3 minutes left. If anyone, a lot of good information today, a lot of hope. From the day you found, when you guys discovered that gene, and you've talked about that gene therapy ever since. And I think that's what everybody is holding on to, is like how wonderful it's going to be. And maybe it will be in the next 10 years. But, these infants that are being born and having to be put on this medication will benefit.
We are doing a trial right now of a medication that's at least targeted to the pathway. And so because of the understanding that we have now from the mutation, we now have an understanding of the cellular pathway. And we're now doing a treatment trial with a medication that targets that pathway. So we're taking steps in the direction much more of treatment now. So we have now the first 2 prospective drug treatment trials for Sturge-Weber syndrome, oral treatment trials, I should say, ever.
Wow.
And so, we've moved from discovering the gene to treatment trials, and that's I think where we want to go.
Do you have any idea of what to expect? Like, are you looking for a reversal?
We're looking for reversals. We're looking to reverse the abnormalities at the level of the cells in the blood vessels, so that we can normalize function and therefore improve the lives and the symptoms. Eventually, if gene therapy goes mainstream, then we can actually, really talk about cure.
That's the most exciting thing. I mean, you must be excited and thrilled. How many years have you worked in this field?
It'll be 20 years next year.
Wow. Great anniversary gift. So Rebecca wants to know if there's any experts that you know of near Louisiana.
Louisiana, I don't know of any experts there.
Yeah, I'm not sure, but Rebecca, you can email me at vbfpresident@gmail.com and let me look through my list around you and see. It may not be a neurologist, but it may be somebody familiar with vascular anomalies. Jelena said, thank you. She said, as my colleague said, it explained to him what Sturge-Weber syndrome is, but life can still be beautiful, and I agree.
And as soon as we're done, I'll answer that email.
Yes, and thanks for sharing all this great information. How, when going to the ER, can we get nurses and doctors to listen to us that the parents, when a seizure occurs, to hurry and get the loaded dose of meds into their system and not drag their feet when they're not familiar with it? You, Dr. Comi, are Ava's neurologist, and we show the letter of importance of quickly giving it, but it seems to never be done fast enough. And then think about the families that don't have that letter.
Yeah. I mean, I think that the letters help some, and the VBF could put together their own sheet like that.
Yeah, I think we should work on that, you and I together.
Sure.
Like a fact sheet, something like that, like how to identify a seizure, what's to happen in an event of an emergency.
Sure.
And then we can put that out. So we are wrapping up. Is there something you'd like to close with today?
Just happy holidays, and thanks for joining us. And also, as we prepare for future events, if there are topics that you would like to have addressed, if you would please send them to us. If there are research questions or problems that you're facing that you would like us to address on a blog or in clinic or in research, if you would send those to us, that would be very helpful.
Yeah, and I think just to close with that, especially the psychosocial issues, let's hear from some of those and see what we can do jointly. So thank you all. Happy holidays, and thank you, Dr. Comi, for joining us on our annual day after Thanksgiving, Black Friday, Sturge-Weber syndrome Facebook Live session. Bye,
Take care, everyone.
Take care.
Bye.